Good morning, ma'am. Good morning, sir.
Adjust your mic.
Yeah.
Okay.
Good morning, my respected teachers, my colleagues. Today's presentation is a path less traveled. I am from IPG MER, a DMPDT. So my story goes with a 9-year-old boy who presented with history of shortness of breath on exertion since his childhood, gradually increasing. He was on NYHA class 2 on presentation. There was no associated facial dysmorphism and congenital anomalies. Physical examination revealed a continuous murmur at the right parasternal border in the 3rd, 4th and 5th intercostal spaces, and initial chest X-ray showed increased cardiac silhouette and ECG showed sinus rhythm with normal axis. So we did echocardiography in this patient, and it revealed the initial echocardiography was apparently normal, situs solitus levocardia D-loop with normal AVVA concordance, normal SPP and pulmonary venous drainage, normally related great arteries. IAS and IVS was intact, and bilateral there was confluent branch at pulmonary arteries, and there was no evidence of any PDA. So we went for 4-chamber echocardiography. The modified 4-chamber echo showed there was dilated RA and RV with abnormal increased flow into RA that was causing volume overload. Subcostal view ruled out possibility of IAS defect, but confirmed there was patent SVC flow within with dilated RA and RV. So modified parasternal long axis view of the aortic valve level demonstrated the origin of a tubular structure from the left coronary cusp. And there was continuous wave Doppler obtained from the communication indicated a high flow velocity with systolic and diastolic pattern. So to trace the origin of the tubular structure, we went for a modified plex view, modified 4-chamber view, and it showed that after origin from the left coronary cusp, the connection was curving posteriorly with a tortuous core and lying between the aortic root and LA. And to see the drainage of the tubular structure, the structure was finally draining into RA near the IVC RA junction, as you can see in this still image. So transesophageal echo was done, which to better delineate the anatomy, and the ostial diameter was around 7.6 millimeter. And transesophageal echocardiography was crucial to determine the origin of the coronaries. Here LMC was originating from the proximal part of the tunnel. So we went for management of this patient on the same sitting. Cardiac catheterization was done, which showed a normal pulmonary artery pressure 24/7 and normal RA pressure 5 mm mercury with QP/QS ratio was 1.33. Aortography confirmed the large tunnel beginning in the left aortic sinus and ending in the RA with normal looking left coronary arteries arising independently from proximal portion of the tunnel. Yes.
It's not there?
Yes, it's here.
Okay.
So the distal portion of the tunnel showed a stenotic opening with aneurysmal dilatation before terminating into RA. It was possible reason for the low QP/QS ratio in this cardiac catheterization despite large size of the tunnel. So here is the final aortogram. In LO10 and LO caudal view, since we managed the patient with device closure of the tunnel. Since the patient was symptomatic and there was evidence of RV volume overload, and closure was done with 14 into 12 millimeter dark trochlear device. So this is the image of closure of the tunnel from percutaneously. And after closure, we have taken showed there was patent left-sided left coronary arteries, LMC and LAD-L6. And post-op echo, there was no residual flow through the tunnel. There was no volume overload was seen in the RA and RV. Here you can see the image of the device placed, and it had showed the normal biventricular systolic function without any flow obstruction of the coronaries or any flow obstruction of the SVC. So this was a case of aorta to RA tunnel in a 9-year-old male child with continuous murmur. It was closed percutaneously under TE guidance to provide symptomatic relief for the child. The patient is now receiving antiplatelet agents and under our close follow-up. So take home message is aorta to RA tunnel is a very rare congenital anomaly and characterized by vascular tunnel between any of the aortic sinuses to the right atrium. And 2D echocardiography with Doppler is the most important tool for diagnosis, evaluation and planning of management of this rare abnormality. Intraoperative TEE was crucial to determine the anatomy of the tunnel, including the tortuosity and course of the tunnel, and most importantly coronary circulation to avoid possible complications after surgical or percutaneous closure. Catheter closure is to be considered especially in symptomatic patients following this anatomical consideration. If the coronary ostia origins independently and no chance of compromise after closure of the tunnel, the opening of the RA end is small and there is no associated cardiac anomaly. So these are my references. Thank you.